Welcome, everybody. Welcome to the National Alopecia Areata Foundation's webinar, JAK inhibitor treatment for alopecia areata, side effects and monitoring. Our speaker today is Dr. Marianne Senna, Director of the Leahy Hair Loss Center of Excellence and Research Unit. I'm Lisa Anderson, Research Director for NAF. Before we start the webinar, I'd like to cover a few housekeeping details. We've disabled chat for this webinar session, but please post your questions for Dr. Senna in the Q&A section. We ask that you keep your questions general in nature. We will not be able to address individual treatment recommendations during this session. This webinar is being recorded, and all registrants will receive a link to the recording via email a few days after the program. And finally, please share your feedback with us. At the conclusion of the webinar, a link to a short survey will pop up in your browser window. Please complete the survey there. We'd love hearing from you. This webinar is part of NAF's You Are Not Alone Education and Empowerment webinar series. We're hosting a diverse group of speakers on a range of topics. We want this series to meet your needs, and we welcome your input on topics that you would like to see covered. NAF gratefully acknowledges the support provided for this series by Eli Lilly and Company. Please note that the information in this webinar is intended for educational purposes only. Before we begin today's program, I'd like to tell you a bit about NAF and our mission. The National Alopecia Areata Foundation is the leading advocacy organization for alopecia areata and celebrated its 40th anniversary last year. NAF's mission is to support research to find a cure or acceptable treatment for alopecia areata, support those with the disease, and educate the public about alopecia areata. NAF's vision is an empowered community with a choice to embrace or live free of alopecia areata. To learn more about NAF's support resources and research and advocacy activities, or to join us as an advocate or supporter, please visit our website at naf.org. And now on to today's webinar, JAK inhibitor treatment for alopecia areata, side effects and monitoring. We are very pleased to have Dr. Marianne Senna with us today. Dr. Senna is a board-certified dermatologist and the director of the Leahy Hair Loss Center of Excellence and Research Unit at Beth Israel Lahey Health in Burlington, Massachusetts. She's also assistant professor of dermatology at Harvard Medical School. Prior to joining Beth Israel Lahey Health in 2022, Dr. Senna directed the Massachusetts General Hospital Hair Loss Clinic for 9 years. She is a leader in clinical trials research for hair loss disorders. Dr. Senna is on the board of directors of the Cicatricial Alopecia Research Foundation and the American Hair Research Society, and she's also a member of NAF's Scientific and Medical Advisory Task Force. Thank you so much, Dr. Senna, for being here today. We're excited to hear your presentation, and I will stop sharing and turn it over to you.
Thank you so much. It's such a pleasure to be here. I really love the opportunity to do these webinars, especially for NAF, because as a physician, I'm able to help one patient at a time. But through these webinars, I feel like I'm able to provide information to many more patients. So I do hope that you find the talk tonight helpful. Hopefully everyone can see my screen. Basically, the talk is going to be on Janus kinase or JAK inhibitors and alopecia areata. And my goal here was really trying to put myself in my patient's shoes and say, what are the questions that I would have around this, and what information would I find it helpful to know if I was trying to make the decision about, is this treatment right for me? What things do I have to be thinking about, et cetera. As you can see from that dated picture, I've been doing this for a while because I'm much older than that picture now. So I hope that some of my experiences and what I show here will be helpful. So these are my disclosures. The outline of the talk will be first to give a brief overview of JAK inhibitors, to review what's known about the risk of JAK inhibitor therapy, and to understand factors that might put people at increased risk of potential serious side effects, and to discuss the proper laboratory and other monitoring for people who are treated with JAK inhibitors. So first, I just want to touch upon an important point that anyone affected by alopecia areata knows, and that is that hair is incredibly unique because it has such important implications for our self-esteem, our self-image, our youthfulness. It's a sign of good health. And this is important in evolutionary biology because it's a display of fitness, right? And I've felt since the beginning of starting this journey that there's insufficient acceptance of hair loss as an important medical problem. And there are statistics out there that support that, right? 8% of female breast cancer patients in a survey considered foregoing their treatment of their cancer because they were worried about losing their hair, right? Because if you undergo a treatment for something and you don't lose your hair or have an obvious visible outward thing, you can keep that private. It's not that it's not difficult, but you don't have to share that with the public. Whereas when you lose your hair and your eyebrows, eyelashes, you're forced to share that with the public, right? And that lack of privacy, that taking that away from the patient, I think can be really, really difficult. And in another study, the fear of losing hair was comparable to the fear of suffering a heart attack. So if you feel, down about your alopecia areata, you should not feel badly for that. There's great evidence to support why patients feel that way. And you should feel validated for sure. Because alopecia areata, especially in its most severe forms, but even if in its mild and moderate forms, can be really life altering, right? We know that. We know that globally affects 2 out of every 100 people. It affects both sexes. And while the initial onset is typically before the age of 30, it can occur at any age. And we know that 50% of patients who develop patchy alopecia areata will go on to spontaneously, without treatment, regrow their hair within a year. But others, most will have a relapse in their disease, so a second or third or fourth episode of it at some point in the future. And there can be more severe forms like the ophiasis form shown here, ear to ear in the back of the scalp, that can be more resistant to treatment. And of course, we have the more severe forms, which can occur in about 15% of patients, where you have total loss of the scalp or total loss of body, facial, and scalp hair. And without treatment, reversal of that degree of hair loss is very rare in studies, usually less than 10% without treatment. So the need for a good treatment for alopecia areata was huge, right? In the United States, until June of this year, there were no approved treatments for alopecia areata, and the treatments that we had were ineffective or painful. So in 2014, my friends and really brilliant colleagues, Britt Kreglow and Brett King, published this case report of a 25-year-old male who had 5 years of extensive psoriasis. He had alopecia areata at age 2, and it progressed to complete alopecia all over by age 18. They treated him with tofacitinib, which is a JAK inhibitor, and not only did it clear his psoriasis, but he grew a full head of hair. And they were like, wow, this is amazing, right? So what's going on in alopecia areata? What's happening underneath the skin? So we know that immune cells go into the growing hair follicle bulb and start this autoimmune attack. And there are other immune cells that hover around the hair follicle, just around it. And the reason why this occurs is not known. It's thought that there are genetic and maybe environmental factors that are involved. But to understand what the JAK inhibitors do, we have to delve a little bit deeper into this process and have a better understanding of the JAK-STAT pathway and what its role is in alopecia areata. So forgive these diagrams. I did them myself on PowerPoint, but hopefully they help you to understand. So again, the immune cells involved in alopecia areata are hovering in and around that hair follicle bulb. And they release these chemical signals here in blue stars called cytokines. And these cytokines are key to perpetuating the inflammation in alopecia areata. So the immune cells in red and green make the blue stars the cytokines. The cytokines then go back to the immune cells and cause them to make more cytokines. And this loop continues and continues and continues, leading to the loss of hair. Now, cytokines drive this continuous inflammation by activating these things called JAKs, or Janus kinases, on the immune cell surface. So if we look at one of these immune cells and we blow it up really big, you see here in yellow, this sort of like backwards L-shaped thing is what I decided to use as the JAK sitting on the cell surface. And these blue stars, those cytokines that perpetuate the inflammation, actually bind to the JAK and cause more inflammation to occur. And that's supposed to be activation and inflammation. So by blocking the JAKs, JAK inhibitors prevent the continuous inflammation loop, so you don't get inflammation, and it allows the hair to regrow. So again, a very, very simplified overview. And this is an example of a patient who was treated successfully with a JAK inhibitor in my clinic. Now, when do I personally consider treatment with the JAK inhibitor in alopecia areata? And this may differ from what your dermatologist does, but this is what I do. So I want to be clear about that. I start thinking about it when a patient has at least 30% scalp hair involvement and it is persistent, not improving, or what we call like whack-a-mole, right? Where one area is growing, the other area is falling out. You just can't get control over it despite treatments. When there's significant social withdrawal or a huge psychosocial component or life impact, right? People are withdrawing from daily life activities, things that bring them joy. They're finding it hard to do their job, et cetera. And if it's involving eyebrow and eyelashes, especially if this is causing functional issues, like you're working out and sweat's getting in your eyes, or debris is getting into your eyes, or allergens and things like that. Now, it's important to note that the FDA approval is for adults with severe alopecia areata, but the severe part of this is not specifically defined by the FDA. Nonetheless, most insurances are defining it as greater than or equal to 50% scalp hair loss, and often may not or will push back on coverage of these in people if that's not indicated in the documentation. So let's talk a little bit about the alopecia areata clinical trials that were just published in the New England Journal of Medicine. So there were 1,200 patients, adult patients with alopecia areata. At baseline, they all had to have at least 50% scalp hair loss or more, okay? And they were randomized, meaning they were like a flip of a coin, randomly assigned to either be on the placebo, AKA sugar pill, baricitinib 2 milligrams a day, or baricitinib 4 milligrams a day. And by the way, just to clarify it, baricitinib is the generic name for Olumiant, so it's the same medication. The average baseline characteristics in the alopecia areata trial, on average, patients were 37 years old, 60% were female. We have the race breakdown here. There were no differences between placebo or either of the baricitinib groups. Importantly, while patients had to have 50% or more scalp hair loss at minimum, these patients actually had more severe hair loss. In fact, on average, we use this SALT, severity of alopecia tool in clinical trials. And you can basically think about it as the percentage of scalp hair lost. So the average scalp hair loss percentage in these patients in the study were 85%. They were missing 85% of their scalp hair. And 44% of them had alopecia universalis or alopecia totalis, so our most severe forms. And what they wanted to achieve, their primary endpoint or the goal of the study, the initial goal of the study, was to have patients go from 50% or more scalp hair loss to having 20% or less scalp hair loss. So they wanted patients at 36 weeks to have 80% of the hair back on their heads. And as you can see, in the 4 milligram dose, which is here in red, on average, about 33.5% of patients reached that primary endpoint at 36 weeks, and around 20% or so of, maybe 18% or so of the patients on the 2 milligram dose reached it at the 36 weeks. Now, what's also really interesting is that when they broke it down in patients with severe AA, meaning scalp hair loss of 50% to 94%, compared that to the patients with very severe AA, so complete or near complete scalp hair loss, right? 95 to 100% scalp hair loss. They saw that the rates of reaching that primary endpoint where they had almost all the hair back on their head was actually much higher in the severe versus very severe. However, it also showed that even our most severe patients could still have really good responses. And it's important to remember here too, that this was patients who were on baricitinib as a monotherapy. So they weren't, being treated with other things as well, oral minoxidil, injections, anything else. And here are some examples of patients who are responders on the trial. So what other considerations are there? Well, questions that understandably patients will often ask is, if it works and my hair regrows, do I have to stay on this medication forever? And I say, well, if you have high blood pressure and you are given a high blood pressure medication, do you expect to take that for 2 months or a year and to always have perfect blood pressure? And after going off of it, no. Because why? Because your body resets to doing exactly what it was doing before you started the medication, right? I wish I could get rid of these glasses, but now that my eyesight has gone, I have to wear them or contacts or something. I can't wear them for a week and then have perfect vision, although that would be lovely. And so it's the same thing with alopecia areata. It is a chronic condition, but what has also been shown in the Olumiant or baricitinib clinical trials is that a very high proportion of patients, nearly 80%, can actually reduce the dose in half once they've had a good response and can maintain that response. And again, that's with monotherapy, with just treatment with Olumiant. Another consideration is, patients will say, well, I haven't had any scalp hair for 15 years. Well, JAK inhibitors work for me. And the answer here is, it's very possible that they will, but it varies from individual to individual. So in some initial studies that Dr. King published on, where he just reported on his experience treating patients with tofacitinib, he saw that the longer patients had persistent hair loss without any spontaneous regrowth, 7 years, 10 years, they tended to not respond as well to the JAK inhibitors. But that being said, my colleagues and I talk all the time and we say, but that's not everybody. Like, there are people who will have not had hair for a long time who will respond. So it's a little bit tricky. The data is sort of suggesting that it might be a little bit harder to get regrowth, but it's not impossible. And until you sort of try it, there's no definite way to know. So scary side effects. Let's talk about this data. So the side effects that are scary are like, why would anyone prescribe this medication, right? It's like serious infections, death, blood clots, heart attack, stroke, lab abnormalities, cancer. It's like, it's like one of these ads where people are dancing on the screen, but there's like all these terrible things that they're saying in the background, right? But let's talk about these because I want people to feel empowered to make the right decision for them, okay? So what's important to know is that this black box warning comes from tofacitinib or Xeljanz, and it comes from a very specific study that was done. So September 1st, 2021, the FDA reviewed a large safety study in patients with rheumatoid arthritis who are taking Xeljanz, tofacitinib. And this study compared Xeljanz with another type of medicine used to treat rheumatoid arthritis called tumor necrosis factor blockers or TNF blockers. And the average baseline characteristics in the tofacitinib safety trial, you could see the average age was 60, 75% female, and the race breakdown was here. And what's important is that all the patients on the study were rheumatoid arthritis patients who were at least 50 years of age or older, and all of them had to have at least one cardiovascular risk factor. We'll talk about what that is in a little bit. In addition, 100% of these patients were also on methotrexate on average 17 milligrams a week. 57% were on steroids, 7% were on TNF inhibitors, and 4% had a history of a heart attack. So these patients were had to have the cardiovascular risk factor, were older, had rheumatoid arthritis, and all of them were also on another very strong systemic immunosuppressive medication, namely methotrexate. The FDA concluded that when they looked at the data, they looked at this patient population specifically, those on Xeljanz, those on a TNF blocker, that the rates in the Xeljanz group were higher for major adverse cardiac events like MACE. These include things like heart attack and stroke, blood clots, and some of these led to death. So when I first read this, I was like, man, let me pull this paper. What are we talking about here? I need to understand, what the rates of this are. So they looked into these different groups. So 1,455 rheumatoid arthritis patients were on tofacitinib 5 milligrams twice a day. Nearly the same amount received tofacitinib 10 milligrams twice a day, and then the same numbers received the TNF inhibitor. So during 4 years of follow-up, the incidences of major adverse cardiac events in cancer were higher with tofacitinib than with the TNF inhibitor. But I think it's important for patients to understand what those numbers look like. So for cardiac events, tofacitinib, the rates of those over 4 years of follow-up were 3.4% versus 2.5% in the TNF inhibitor. So yes, higher, but by about a percentage point. Okay. And the rates of cancer, and the most common cancers were lung cancer with tofacitinib and breast cancer with the TNF inhibitor. 4.2% in the tofacitinib arm, 2.9% in the TNF inhibitor arm. So again, about a percentage point higher. And so what the FDA said was like, listen, and it's the right thing to do. They need to do their job and talk about safety stuff when they find something like this. But basically what they said is, doesn't matter if these other studies haven't found it. We haven't really had it being used in this patient population for long enough to be able to adequately evaluate it. And we found this in Xeljanz, so we're just going to make sure it's on the label of every JAK inhibitor that comes out. Just so you understand those black box warnings. So who might be at higher risk for these scary sort of side effects? People over the age of 65, people with a previous history of cancer, people who are previous but especially current smokers, people who have cardiovascular risk factors, so obesity, diabetes, hypertension, coronary artery disease. And if you're curious, like, where do I kind of stand with this? There are cardiovascular risk calculators available online where you can plug in your own information and kind of see what your cardiovascular risk is. What about blood clots? Well, people who are at risk for blood clots are those who are really immobile, people who just had a surgery or a long hospital stay, for example, or people who are immobile because of arthritis or something like that. Certainly older age, if you're overweight or obese, if you have a personal or family history of blood clots, if you have a recent or recurrent cancer, sometimes right after pregnancy, and some estrogen-based medications like hormone replacement therapy and things like that could also put people at higher risk, as well as injury or trauma. So what was the data in alopecia areata patients for these side effects? Because I think that's also important to know. So again, reminder that these are 1,200 patients, placebo, baricitinib 2 milligrams, baricitinib 4 milligrams. The average age of these patients, 37 was the average age, 60% were female, and this is the race breakdown. And there were no, like I said, statistically significant differences between the groups, but notably this is a younger group. Remember, the average age of that other trial with the Xeljanz, the average age was 65. So when we look at infections, not really hugely statistically, or significantly higher rates of all infections between all the baricitinib arms and the placebo arms. Serious infections were more common in baricitinib, but still the percentages were very, very low. And we'll talk about how we monitor for some of those before a patient starts the medication. Shingles was a little bit higher in the baricitinib arm, but at 1.1%. Herpes simplex was actually higher in the placebo arm. Cancer rates were same between placebo and the baricitinib arm. And there was one patient who had, I believe, a heart attack in the baricitinib arm. However, again, this was a patient who had multiple cardiovascular risk factors. I believe it's like obesity and diabetes or high blood pressure, coronary cardiovascular disease, something like that. So someone who was high risk. There can be laboratory abnormalities that happen, but the ones that are significant, in other words, the ones that would require dose reduction or stopping the medication, like low white blood cells, happen less than 1% of the time. Low lymphocytes, 0.4% of the time. High platelets, about 1% of the time. And notably, people who had blood clots and stuff did not have like high platelets, or there was no correlation there at all. In other studies, not in this study. High LDL and high HDL are probably the most common laboratory elevations or abnormalities that we see, with both the good and the bad cholesterol being bumped up. And so that does need to be monitored. It should be fasting. I have not yet to date had to treat anyone with a statin or anything like that. But certainly, if it were to bump up high enough, then that would be something that would have to be treated according to the current guidelines. And then elevated liver tests were seen equally between the baricitinib arms and placebo. Now, for monitoring, what do we do? At baseline or prior to starting the medication, we screen for potentially serious infections that someone could have and not know that they have them, right? Like latent tuberculosis, if you were accidentally exposed, hepatitis B, hepatitis C. We check a complete blood count, which is your white blood cell, your red blood cell, your platelets, et cetera. We also do a complete metabolic profile, and we're looking to see, do you have good kidney function and liver function at baseline? Because if people don't, then there could be considerations about whether or not it makes sense to start a medication like this. We do a fasting lipid panel, to see where your cholesterol is at baseline. And then I screen for risk factors. So I have a sheet where I kind of review, what someone's cardiovascular risk factors, clotting risk factors, cancer risk factors. And I always make sure that patients are up to date with their age recommended screening exams, like colonoscopies and mammograms, because, time goes by really quick. Sometimes you don't realize, oh my gosh, it's been 2 years since my mammogram, right? And so it's not because I'm worried about these medications causing a new cancer, but, if someone had something very small and they're lapsing on their age recommended screenings, any immunosuppressive medication, could make that situation worse. So it's always important to be up to date with those at baseline, but especially if you're on an immunosuppressive medication. So what do we do for follow-up? Well, what I do for follow-up is once a patient has started the medication, 3 months later, I do a complete blood count again, complete metabolic profile in the fasting lipid panel. And then assuming it's normal, which it is the vast majority of the time, then we do, and there's no dose change, then we repeat it just every 6 months thereafter. And I again, always annually at least ensure that patients are up to date with their age recommended screening exams. So in summary, the risks of JAK inhibitors are not zero, but they are low. Potential patients need to be screened to ensure they're not at increased risks, and labs need to be routinely monitored. Patients over the age of 65 with cardiovascular risk factors, smoking history may be at increased risk of serious side effects. The black box warnings have come from data in the rheumatoid arthritis population who are also on other concomitant immunosuppressive medications and who had cardiovascular risk factors. And trials are ongoing. Longer observation periods will help us to assess long-term safety of these medications. So thank you. I hope you found that helpful. And I wanted to make sure I left enough time for questions so that I could make sure that I was addressing the things that were most important to all of you. This slide shows all of my amazing, wonderful mentees over the years who I've had such a privilege to work with. So I thank you all very much, and happy to take any questions.
Thank you so much, Dr. Sena. That was a great presentation. you can see the reactions from the audience. I love seeing
So
them.
sweet. Yeah.
Yeah,
Thank you.
that's awesome. So we have quite an audience today. I have over 700 people here. They continue to pose questions. So folks, please put your questions in the Q&A section, and keep in mind that we'll be more likely to answer a question if it's a general question rather than something very specific. And I will go through as many as we can. And we have the gamut here, so specific questions about side effects to just JAK inhibitor use in general. So one question that I want to ask is, someone posed the question, do more selective JAK inhibitors have a better safety profile than less selective ones like Xeljanz? So maybe you could talk about that a little bit.
Yeah, so there's some thought that some JAK inhibitors might be more associated with causing like clotting and things like that. We don't have that data in the alopecia areata community. It has not been a signal with the various JAK inhibitors that we've used. But there is thought that because of the way that certain JAKs, so there's like JAK 1, 2, and 3, that these non-selective or pan JAKs that block all of the JAKs might be at higher risk of that.
Right. You were talking about JAK inhibitors that are taken orally, but there's a question about topical JAK inhibited in topicals, specifically generic topical Xeljanz in pediatric patients. Are there similar side effects?
So it's a great question, and one I should have thought to address in the talk, actually, because it comes up a lot. So with the topical use, I think about it just like with topical steroids, right? When you take an oral steroid, the side effects are very different than if you're using a topical steroid, right? Yes, if you were applying head to toe on like, abraded skin or like eczema or something skin all over head to toe, there might be some absorption through the skin that could get into the bloodstream. But use of it on the scalp, on intact skin, there should be no significant absorption into the bloodstream. So at first, like years ago when I was using this, sometimes in patients, I would, routinely check labs and stuff. And then I stopped doing it because I just didn't see it being a real issue. So no, I mean, again, if you're overusing it, or if there's a huge body area being covered, that's always a potential. But with the use on the scalp, eyebrows, eyelashes, that shouldn't be an issue, no.
Okay, thank you. This question is about switching medication. So if someone's using Xeljanz and doing well, should that person, or how do you think about switching?
We have no idea. In fact, when Brett and Britt and Justin Coe and all of us Natasha Mizinkovska got together and we talked about this, we were actually like, we don't know the answer to that, because we didn't really have access to baricitinib. So a lot of our patients' insurance was only covering tofacitinib. So that's a really important question. And I don't know how to answer it for my own patients. So more to come on that. There are some patients who have to switch, right, because of insurance coverage reasons or something else. And so we're trying now to collect data on those patients to better understand, what does that look like, so that we can bring that information to patients.
Okay, thank you. When someone starts a JAK inhibitor treatment, is it typical to continue to see hair loss before growth begins?
Absolutely. So especially if you're having rapid loss, it can take a good couple of months for things to slow down before someone starts regrowing. So don't lose hope in that. The other really important thing that I'll just mention to piggyback on that is people respond at different rates. Some people will come back at 3 months and have regrowth. And I'm like, wow, other people, it can take closer to a year. Usually by 6 months, you have some sense of how a person might respond to JAK inhibitor treatment. But I've had patients who have even taken a little longer than that. So I usually will give people with extensive hair loss up to a year or so to see how they're doing.
Okay, great. Someone asked the question, how long, the patients in the clinical trials, how long had they had alopecia when they were?
So on average, it's a great question. So it's not only when was the first time you ever had alopecia areata. So say you got it in childhood and it was a patch, and then you regrew with treatment or without, and then later in college you had another flare and then you regrew, and then it's the current episode, the current, like right now, the level of hair loss that you have, how long has that been going on? So that's the 7 to 10 years that I was talking about during the talk. in the clinical trial, patients, I think, couldn't have any more. I can't remember off the top of my head if it was 7 or 8 years of current episode duration, but on average, it was 4 years of current episode duration. Okay.
Thank you. The studies seem to be focused on scalp results. For those of us or people, the person asking the question with alopecia universalis, are there any results for the rest of the body?
Yes. So, we don't have great tools for measuring the rest of the body. And a lot of people are totally fine, especially women, if they don't get their hair back, right? But we did measure eyebrows and eyelashes. And on the 4 milligram dose, 35% of patients had significant regrowth in their brows or eyelashes at that 36-week primary endpoint mark.
Okay, great. Do we know if there are any effects of JAK inhibitors on future fertility? Is anything known about that?
So we don't, but I can tell you what we do know. So number one, this should never be taken on purpose during pregnancy, but whether it's a patient with rheumatoid arthritis or something else, there is this registry that's really great called Mother to Baby that actually keeps track of the outcomes of inadvertent exposure to various medications. And at least 2 years ago when we last looked, and we did a little poster on this for one of the meetings, the most common outcome for a woman inadvertently exposed to a JAK inhibitor during pregnancy was a normal, healthy child. Okay. That being said, it has not been tested in pregnancy and it's not something I recommend. But the other thing that I can say is that I have not seen it impact future fertility. But what can happen is that women will be on it. They will decide, okay, it's time to be pregnant. They will have a full head of hair. They will go off of the medication to get pregnant, and they will lose their hair. And it can be understandably devastating, right? But in my experience, and it's 2 patients that I have, but in my experience, it has not impacted their ability to get pregnant. And in both cases, and one, it was multiple pregnancies, so off and on, or on and off, they were able to regrow again when they restarted the tofacitinib. Okay, but it can be devastating, obviously, when you lose your hair after having it.
Great. Thank you for sharing your experience with that. This is sort of related. This person wrote, I've heard that if one stops taking a JAK inhibitor, the loss returns worse than before. Is that true?
I don't think so. No. It's rare that I have someone coming up, but that's not something that I've heard. The way I would explain that in cases that might be reported is that your alopecia areata was probably heading that way anyway, right? So maybe you started it when you had 50%, but had you not started it, you probably would have been 100% scalp hair loss. That's the only way I can kind of explain it, because it's basically your body goes back to doing whatever it was doing, right? Or whatever it was going to do. Like I said, we can reduce the dose for patients and have really good outcomes. But usually 3 months of being off it, and this is another important point because people will be nervous, if they get sick or something, I can't stop it, I'll start losing my hair. It's not really a week or something like that. It really has to be 2-3 months before you start to see a really big shed.
Okay, great. There are a number of questions that ask about treating pediatric patients with JAK inhibitors, and I know that could be a talk that could be a talk on its own, but could you sort of give an overview of, can these JAK inhibitors be used to treat children? When will there be more data about children? What's the expectation for what's coming down the pike?
Yep. So I do believe that there are plans for clinical trials in pediatric patients. So that is going to be incredibly important in shedding more light on this. I can speak directly to my personal experience treating pediatric patients. I think my youngest is probably 9 years old, with JAK inhibitors off label for the past 5 or 6 years. They've all done great. When do I think about it? Why 9? Why not 5? Because really 5-year-olds don't notice very much. It's rare for a 5-year-old to be aware of their peers and having their alopecia impact them. My daughters are 8 and 11, and I can tell you that there's a certain age where that starts to become very obvious, right? And And that's when you start to see the psychosocial component really playing a role. They don't want to do sports. They're crying all the time. They're sitting in their room. They don't want to be around friends. They're getting bullied, right? That is when I start to say, you know, any potential small risk of this medication. Now, this is me. Everyone has to make a decision that they feel best about. But I start saying any small risk that could happen, what's happening to this child's life and development right now at such a critical stage is, in my mind, more harmful. And so that's when I think about considering it with the parents.
And do we know about the side effect profile from?
Again, we only have like sort of case reports and case series. Britt Kreglow, I believe, published on this. And again, in my personal experience, I haven't, even during COVID, haven't seen any like crazy infections. I haven't seen crazy lab abnormalities. I haven't seen, God forbid, cancer or anything like that. Children tend to do really well. In my experience. But again, we do need bigger, large, robust clinical trials to say that, you know, with more certainty.
Great. We think those are coming. I asked you about topical JAK inhibitors earlier, and we were talking about side effects, but can you give a sense of where the research stands on that? Are they effective?
So here's the trouble with topicals. It's not that they never work, but in my experience, they work in sort of two populations. One, really, really little people, right? Like the 5-year-old where they want to treat it, and really, really much older people. Okay. And I don't know if that's because the skin is thinner and things absorb better or what's going on there. But when I've tried it in older kids, adolescents, adults, the sense I get is twofold. One, because the inflammation is so deep in alopecia areata and topicals kind of penetrate right here, doesn't penetrate deep enough to get rid of the inflammation. But also, even if people start to regrow hair, it's really hard to live a normal life and be, you know, putting cream all over your scalp effectively, right? And because it's a cream, the solutions and things like that don't work as well. So because of that, I feel like for people who have extensive hair loss, I tend to recommend the oral more.
Okay, thank you. Don't know if you will know the answer to this. Can you elaborate on the mechanism of weight gain while on a JAK inhibitor?
So recently I heard a hypothesis on this, but I don't know that it's fully understood. I will say I probably have 1 or 2 patients in 6 years who have complained about this to me. So in one case, I was like, you know, people can understandably be very depressed when this first happens to them. And part of depression is, you know, some people eat more, some people don't eat much at all. And so part of me was like, you know, could that be playing a role? But I think my other patient I sort of said, no, you know, I think this is like a real side effect. But if you look at the clinical trials, the rates of that are pretty low. And it's not something I have to say I routinely hear. But I don't think anyone really truly fully knows the mechanism of it. It's a great question.
Okay. You kind of addressed this, but maybe slightly different. Is there an age range for treatment? So this question is specifically about children, but I know there's but on the older adult side would be interesting to hear that again.
Practitioner, right, until we have FDA approval for all of these medications, hopefully, you know, is going to have a different threshold for what they feel comfortable doing. For me, the youngest I think I would do is 9. I don't think I'd have any cutoff with the upper limit of age, but a lot of that would depend upon the person's other health issues. If this is a healthy, active, you know, 75-year-old who wants to treat their hair loss, I'm okay with that. But if it's, you know, a 75-year-old who is obese and a smoker and has diabetes, that's a different thing. And, you know, I really take the time to have conversations with patients and review stuff and say, listen, the risks are low, but for the people this happens to, they're people with your risk factors. You know, and it's sort of like, are you, you know, this is the risk. Do you want to take on that risk? And so you just try to have an honest conversation with patients to see where they're at.
Okay. This question, if somebody has, for example, a large patch on their forehead, doesn't reach 30% hair loss, but maybe it's like 10%. do JAK inhibitors work for relatively mild alopecia areata?
Yes, but I would not reach for it in those cases. I would say intralesional Kenalog, 5 milligrams per milliliter, no higher, every 4 to 6 weeks, times 3 or 4 times, plus minus topical or low dose oral minoxidil. And the vast majority of the times it will regrow.
Thank you. When taking a JAK inhibitor, how long does it take before someone might see noticeable improvement?
Yeah, so like I was saying, some patients will come back and be like, whoa, I wasn't expecting this at 3 months. You start to get a sense around, 6 to 8 months of how someone is responding. But I've had patients take, a year, 14 months to really start responding. So varies a little bit, but I think usually by 6 to 8 months, you can get a sense of how someone might do.
Okay, great. I'm going to sort of paraphrase this. How would you, the question is how to find a healthcare provider to take you through the process, but maybe you could talk about how to talk about it with your healthcare provider if someone is not quite as expert as yourself. Do you have recommendations for people in the audience about starting that conversation?
This is really hard because there are very few of us who specialize in this area of dermatology. And we have been using these medications for alopecia areata for a long time, right? Or longer than people who don't see patients with alopecia. So we have a different comfort level, right? We are familiar with the data. We understand how to talk about it with patients. And that's why too, we try to educate not only patients, but dermatologists around exactly what we talked about here tonight. So to empower them to feel comfortable in talking about it and prescribing it for patients who are good candidates and who want to take it. Finding the right person is really hard. I know NAF has a database, right? Or
We are working on it and
on a list of
we'll be
physicians.
launching it. Yes.
Yeah, so that would be a great place to start. You'll probably have your best chance of finding someone good at like one of the academic medical centers to start. So if you have an academic medical center near you with a dermatology department, someone who treats complex dermatology or psoriasis, there'll be a person who's more familiar with these types of medications because they're used in psoriasis and atopic dermatitis or eczema and things like that. So that's my best sort of suggestion there.
Great, thank you. Back to more general questions. Should you stop medication if you get COVID or some other infection?
Yes. So I usually will say, if you have some sort of infection, COVID, flu, it's a good idea to pause treatment for like a week and just allow yourself to recover before restarting it. That's what I usually will recommend.
Okay. Who can prescribe these medications?
I think any MD doesn't have to be a dermatologist, doesn't have to be a hair specialist in dermatology, but again, it's just a level of comfort with the class of medications and particularly their use in alopecia areata that's important.
This is an interesting question. How do you factor a person's environment or lifestyle in prescribing medication? And you can say if you're not able to answer, if you have a lot of exposure, I think the person's thinking about exposure through kids or through their workplace that might get sick more frequently. Do you take that into consideration?
I mean, all I can say is that the clinical trials for the JAK inhibitors, a lot of it occurred during COVID when no one was vaccinated, right? And even my patients who were on it off label at the time, I never had someone be like, I was so sick, I had this serious infection. And, I have patients who are teachers, I have patients who are physicians, so it's not that they're not around people, like this. So I can't say in my experience that has factored into my decision. Certainly if you're a teacher in an elementary school or working in a daycare, you might think about wearing a mask, when rates of flu and COVID are really peaking. But outside of that, I think patients tend to do pretty well.
Okay, great. I'm trying to find some different questions. Questions about insurance and getting coverage. This question is, how do you fight the insurance to get prior authorization for this medication if they're denying it by saying it's not approved for cosmetic purposes? This is another topic that we actually have had webinars related to this, but we know it's difficult. If you have anything you would like to say to us.
So maybe I've been lucky, but I haven't really had any rejection since the FDA approval. And if I've had one or two, we've been able to successfully appeal them. Medicaid, Medicare tend to push back way more than commercial insurances. Lilly also, and every office has someone who handles like the interactions with the insurance because it is more than a full-time job. But they should be aware of the fact that Lilly has, as long as a patient has commercial insurance, so unfortunately they can't just have Medicaid or Medicare, very unfortunately. But if they have commercial insurance and despite appeals it's being denied, Lilly will actually cover it in a bridge program for 3 years. So they have a patient assistance program where patients will pay nothing or very little to be able to get access to the medication.
Okay, that's good to know. This question is about recurrence rate even while being on JAK inhibitors. Are there data about that?
There's not like super great data on it, but I can again speak from my own experience. The one place where I've really seen people kind of relapse a bit is one, if we taper them too quickly. So really, if you're tapering your dose or you're on your full dose, you should stay there for a year. And if you're thinking about reducing the dose, you want to sort of do that slowly. Because like I said, it could take 2 to 3 months to see if someone's going to shed from a reduced dose. So that's one thing. But the real big thing has been COVID. So not just like asymptomatic COVID or mild COVID, but COVID with fever or if someone's feeling really lousy, it can actually cause them to have an uptick in their shedding. And I've been pretty successful in most cases with just being able to treat those areas with injections and get it back again.
Okay.
There have been, maybe 1 or 2 patients where that's been a little bit more resistant. But it's in places like in the back of the scalp that can be more resistant. But, I can think of 1 or 2 cases of that.
Okay, great. Lots of questions specifically about ages that are appropriate to take it, younger ages. I think we've kind of addressed those. There are some questions about for people with alopecia universalis. Have you seen success with regrowth?
Definitely.
And
Definitely.
Okay, go ahead.
No, I was just going to say the pictures that I showed, right, are patients who had alopecia universalis. So absolutely. And in fact, when I was using this off-label before the FDA approval, it was like all patients with universalis and totalis, and they've done wonderfully. Yeah.
And this question is, how long did it take in those cases to regain hair?
So the trouble here is, especially for women who wear their hair longer or men who wear their hair longer, right? They don't really feel like themselves until they have like their hairstyle back the way that they like it. Regrowth, like I said, you can start to kind of see how someone's going to do 6 to 8 months, not for it all to be coming in, but to kind of see how they're trending. But the problem is once the hair starts growing, it's only like a centimeter or like a half an inch a month, right? So if you wear your hair longer, it takes a while to get there. Right.
Mm-hmm.
So that's the bigger thing. So I'm not sure how the person was phrasing the question, but that is something to keep in mind too.
Okay. Are the side effects increased due to age? Or is there any info on that?
So I'm not sure, but I have not seen that in my own patients, and I have patients in all different age groups. I would say, again, this wasn't a signal at all in the alopecia areata clinical trials, but every decade of life that we get older, our risks for common cancers, prostate cancer, breast cancer, right, increases. So especially in that patient population, I'm making sure that they're getting their annual age-related screenings. I haven't had an issue to date, but that if there's one thing that I'm really thinking about in that patient population, it's that, in addition to whether or not they have any other comorbidities.
Okay. Here's an interesting question. Would being on a JAK inhibitor for alopecia possibly also reduce arthritis pain?
If it's inflammatory arthritis. If it's osteoarthritis, probably not.
Okay. We are getting close to the top of the hour, so I'll ask a couple more. How many patients have you treated and seen success with?
I think almost all of the patients that I've treated, I've seen success with. I have to have treated close to 100 at this point. 60 to 100, somewhere in that range. More now because it's FDA approved, so it's just easier to get. But I'd say the vast majority of my patients have responded beautifully.
You may have already addressed this also, but are individuals at increased risk for things like flu and COVID taking JAK inhibitors?
So of the common side effects that were more commonly seen with Olumiant or baricitinib, upper respiratory tract infections were the number one thing. So yeah, you're more susceptible to things like cold, flu, COVID. But what's kind of interesting too is baricitinib is actually FDA approved for the treatment of severe COVID, because it blocks that cytokine storm that really severe patients have. So it's just kind of funny. I think it's like an interesting thing. So, but yeah, so that's why I tell patients if they develop anything like that, that they stop and allow themselves to recover. But again, that's what the data says. But in my personal experience, it's not like my patients who are on JAK inhibitors over the years have been like sick all the time, or that they're saying like, oh my God, I'm constantly getting sick. Like even the people who have little kids themselves, I haven't seen that. But it is a consideration.
Okay. Any evidence of psychiatric effects in the clinical trials?
So I can tell you that I call it the smile factor, because you take the pre-picture and they're like, understandably like this, and then you come back and they have hair and they're smiling. So that to me says it all, right? Like they feel like they have their life back, which that's how patients describe it to me. The problem is that we don't see bad psychiatric effects, that's for sure. But it's very hard to reliably measure quality of life and the impact of alopecia areata on patients. There are a lot of reasons. We've talked, Brett and Natasha and all of us have talked about this ad nauseum. There aren't great tools to measure that effect. But I will tell you that when patients do well on this, they're incredibly happy.
That is a great positive note and probably a good place for us to stop. I'll just read one comment that came in that said, Dr. Sena is not only incredibly knowledgeable, but she's superb at explaining complex material in very simple terms.
Oh, thank you.
Thank you.
Thank you.
Thank you for being here and for sharing your expertise. We really appreciate it. I agree with all the hearts that are showing on our screen. And we just can't say thank you enough. So
of course, my pleasure.
Thank you. I will be sharing my screen again and wrapping up the webinar. So thanks.
Yeah, thank you.
Okay, give me a second. All right. Well, thanks, Dr. Sena, and thank you to the audience. Am I sharing the screen? Yes. We thank you for joining the webinar. We had over 700 of you on here today, which is really incredible. We thank you for your questions, and please share your feedback with us on the webinar so you can help us plan future presentations. A link to a short survey will pop up in your browser window at the end of the webinar. Your feedback is appreciated. And again, thank you to Eli Lilly and Company for its support of this webinar series. Our next live webinar will be a patient guide to clinical trials and drug development, phases and terminology explained. Join us to learn about drug development, how clinical trials are planned, the phases they go through, and the role that patients play in clinical trial conduct, as well as things to consider when evaluating whether to participate in a trial. Our speaker will be Danielle Quarles, who's Director of Clinical Operations at Sana Biotechnology, and who is also a member of the NAF community. She is a parent of 2 sons with alopecia areata. This live webinar will take place on Wednesday, February 15th at 7 p.m. Eastern, and registration for this webinar is now open at naf.org/webinars. NAF offers a number of resources and programs to the alopecia areata community, including support groups, our youth mentor and legislative liaison programs, as well as news and webinar links and how to get involved. To learn more about NAF and the resources we offer, please visit naf.org or email us at support@naf.org. And that concludes today's webinar program. We thank you for joining us, and we look forward to seeing you on the next webinar. Okay, take care, everybody.